So it is my honour, and it is an honour, to introduce Professor June Andrews. Now, many of you heard June talk yesterday, and that's why you're here now, obviously. She's passionate, she's got clarity, she's got humour in her presentation. It's a very forceful message, no matter what the topic is. It was fantastic yesterday, June. Thank you very much for that. I did notice Barry might not be here. He said he couldn't make it. But if I hadn't mentioned that, we ought to be looking around going, oh, gee, Barry. For those of you that weren't there, ask someone who was. So, June, he didn't take any offence, June. Don't you, Barry? You just told him to relax. Good. Oh, when you got up this morning. No. Right, so June is the Director of Dementia Services Development Centre, School of Applied Social Science, University of Stirling in Scotland. And I think the School of Applied Social Science is not just Stirling or Scotland based, it also has offices in Belfast and London. You'd look at this and you'd say this was probably June's calling right from day one because of her knowledge, her passion for it, but in fact that's far from the truth. June, in fact, had quite an interesting career path. I think undecided at the start. I mean, I'm reading there, you did philosophy and English literature. That's not probably where you've ended up. It's probably helped you immensely, but it would appear that this wasn't your planned destiny at the start. You did then go into nursing and then became a trade union leader. Hence the negotiations reference from yesterday, and as you can see in the brief, June has led the negotiations for the Scottish Nursing Corps of 35,000 nurses, and quite a forceful negotiator, I'm sure she was. Subsequent to that, June took up a role in the civil service, a calling, one could say, but I think it would be fair to say you were headed for a bureaucratic middle and late career life, but an opportunity appeared, and this opportunity is the one she has right now. And look what's happened. I would probably suggest, just in talking to you, June, that was probably one of those great moments in your life that you're really, really pleased came along. June has published, so she has several publications. One very recently in February of this year called Dementia, the One-Stop Guide. And I'm told that this was outselling 50 Shades of Grey in the last few weeks. And her response to that, sex is so yesterday. Now, you want that book, it's a great read. It's $30 down at reception. You can get it here. This modern world, isn't it marvellous? Now, somewhere in my research, I found this one sentence which I just thought sums up June. Dementia expert, consultant, teacher, nurse, writer and researcher working worldwide in statutory, third and private sectors. Busy woman across a lot of topics. And today we're very, very privileged to hear Professor June Andrews.
Thank you very much, ladies and gentlemen. The only really remarkable thing about my career is the fact that I've managed to do all of that and I'm only 29. So today we're going to be talking about how to improve care of people with dementia. My being here is part of a fantastic year that I'm having, which is called the Dementia Festival of Ideas. You can follow the Dementia Festival of Ideas on Twitter. But this was an idea that we came up with because we had a practical problem. My centre is supported by charity, and we'd been making a number of applications for funds and we were getting turned down. We couldn't understand until we got some feedback that said we already had too much money in our pot, and people weren't giving us money because they thought we had some. We thought it was prudent to keep some. So we spoke to the committee and we said we've got to spend all the money. So they shook it all out their bag and I took it. And the thing we're doing with that money is having the year-long Dementia Festival of Ideas. And when you go on our website, you'll see the Ideas Festival site. And what you'll see there is we're doing a whole range of things in the course of year one, which is an international conference in Birmingham in November, to which you'll be very welcome. We're hoping we'll have at least 1,000 guests there. We've got an enormous exhibition. But part of the Festival of Ideas is looking at the next 25 years. Our Dementia Centre has been around for 25 years, and we've focused a lot on improving services, doing research on what makes a difference and trying to get that research put into practice. But what we want to do now is to work out what it is people think about dementia and why they think the way they do about dementia. Because unless you know that in your own community, you're not going to be able to make change and improvement. The way people frame dementia absolutely determines what they think about it. And an example I can give of that is some of the communities where we work, where there is a high percentage of people of Chinese origin. Now, in traditional Chinese culture, I mean, that's huge, but in some traditional Chinese cultures, growing old is growing into a period where you're regarded with great respect. And having the changes of ageing that come with dementia, which they think of as senility, senility is a natural part of ageing, and so you naturally respect somebody if they're what they would think of as senile. Now, in our Western culture, we think currently it's really, really important for people to think of dementia as a disease. So we've got a good reason for that. That is that we would really like those people who've got dementia which is amenable to medication. We want those people to get that medication, but you can't get that unless you think there's something wrong with you. So we batter away and we persuade these Chinese communities that their old people have got a disease. And then they say, okay, right, we give in, they've got a disease, what can you do for us? And the answer often is nothing. So what we've done is we've pulled the plank out from under a community way of thinking, which was perfectly satisfactory, and we've got nothing to put in its place. So one of the reasons why we're having the big ask is we want to know what people think about dementia, and we don't automatically want to say, we've got the right idea, this is what it is, we're going to tell you how to feel about it. Because it's a thing that we've seen governments do from time to time. Now, everybody here must know what a social movement is. It's where people get together and they build from the ground up. And certainly in recent years, the United Kingdom government, particularly the one based in Westminster and London, has had departments of people who've said, we're going to start a social movement. And we're thinking, no, that's not what governments do. But they particularly wanted to start a social movement around dementia. And that somehow feels like riding over all the individual views that people might have about dementia and saying, no, our view is the right one. So if you do one thing after my presentation today, or should I say all my presentations this week, if you do one thing, then please click onto that Big Ask website and add your voice to the voices around the world that we're asking about what we think about dementia. And I know a number of you have been to Poor Chiquita. This is about the 5th time you've seen this slide this week, but a number of you have been to presentations. If you're wondering what the Stirling Dementia Centre is, we're really very independent. That comes from the fact that no one person gives us a lot of money. That sounds like a complaint, doesn't it? But at least the government doesn't give us money, so we can criticise them. We've been working, as I say, for over 25 years, and unusually for an organisation like this, I'm only the 2nd director. Pay tribute to my predecessor, Professor Mary Marshall, who, although she is officially retired, Mary is still tramping around the world, giving the messages and giving the help and support to people with dementia and their carers that she's done for all her working career. We're called in when people are in trouble, and that's in 2 ways. Sometimes we're called in to help people get better, and sometimes we're called in, for example, by government when people have got so bad that you literally have reached stages where staff have been criminal in their activity and police action might happen as a result. So although we have a lot of fun and we have a lot of laughs, we're in a very, very serious business. And we've got a real hope that what we do is based on research evidence. Now, kindly, before we came, I was given a briefing of what kind of topic areas are of interest to you here. And I'm just going to move this microphone a tiny bit so I can stand here and read this. So if the people at the back can't read this, this will be available on the slides later. But the sorts of areas that are of interest here, I've been told, are family education, training of general practice, a range of things. And I'm hoping that as I'm doing my presentation, I'm going to be able to illustrate things that can be done internationally based on the areas that I was told are of particular interest. But the fundamental thing, as you would have heard me say if you were here a couple of days ago, is to consider the impairment. Now, I find when I'm talking to journalists, it's really, really hard to talk about dementia. I feel as if I'm educating the world one by one through each individual journalist, because the general public really don't understand what the words dementia and Alzheimer's mean, and that's because journalists don't understand. And so for the purpose of this discussion, what I'm going to do is assume that dementia is the impairment that a person might have. Now, lots of people think of it as a memory problem, although the people with dementia say the memory problem is not the hardest problem, and certainly their carers say it's not the hardest problem. There's a problem of not being able to remember things, but then not being able to work them out, because all of us can't remember things. Everyone has been asking me since I've been here, where are you going next? And to be honest, most days I can't remember. But I know that when the morning comes that I have to leave, I'll pull a sheet of paper out and some tickets, and I'll look at it and I'll know exactly where I have to go next. So it's not a problem. It's only a problem if you can't remember things and you can't work it out. And of course, one of the things I've learned is that it's really useful to know that I'm going to Wellington next, because everybody's going to ask me. So I've learned to say, yes, I'm going to Wellington. Actually, I checked this morning, it's Auckland. So but that also illustrates that sometimes it doesn't matter what you say. My dad used to visit my granny in the care home and say, have you had your lunch? And she'd say no, and she had, because it was all over her. He knew. But the point was, he was anxious about the fact that she couldn't remember that she'd had it. And he'd say, of course you have, of course you have. But her answer didn't really matter. We ask each other so many questions where the answer doesn't matter. My mother died a number of months ago, and my dad, every time he sees people, they say, how are you? And that's really hard for him, because what he wants to say is, you know, after 65 years of being totally dependent in this woman, I'm shattered and I want to die. But what he has to say is, I'm fine. Wouldn't it be so much better if people didn't answer the question to which they do not want to know the answer, but they said things like, what are you doing? And then he could say, well, I'm doing the garden, and I'm going out for lunch, and I'm doing this. So we so often carelessly ask people questions to which the answer doesn't matter. It's of no concern to you whether I'm going to, where did I say I was going? I can't remember. Wherever I'm going next. What you're doing is communicating to me that you care about the fact that something is going to happen to me next, and that you've had some of my time and I'm moving on, and you want to indicate that that matters. But please try and find a way for someone with dementia who really can't work out what's happening next, that you don't ask them the kind of question that's going to put them in the position I've been in, or that my dad is in, where he has to try not to worry about the fact that he's being asked a question that is really just a little bit too hard to answer. And then, of course, the majority of people with dementia are old or very old, so they have the normal changes of ageing. I have to be taught that a pair of glasses is not a hair accessory, but if I ever forget that, I'm going to have difficulty the next time I've got something I have to read. And it's very, very stressful. So if you're going to do one thing to improve the care of people with dementia, what you have to work on is their stress. You have to help them be as relaxed as I am. I find carbohydrate and alcohol helps me, but everybody's different. And other people's responses is really important. So one of the little books that's on the desk downstairs is a little book that we produced with research that was done by the University of Leeds, and it illustrates part of what's important about what the Dementia Centre does. Because the people at the University of Leeds are so clever. You know, they're like a person with two heads, the amount of brains they've got. It's incredible. And so they did enormous amounts of research into what it is that bothers the carers of people with dementia. The reason why this is important is Professor Shubi Banerjee from England has done some research that shows that if you have a carer living with you at home, you have a 7-fold protection against institutionalisation. So you're 7 times less likely to go away or to be put away at any point because of your dementia if you've got a carer living with you at home. And there we have all this government money internationally being poured into pharmaceutical companies to try and find a drug that will improve the memories of people with dementia. Now here's the list. Even people at the back of the room can probably read it and tell me, is memory problems there on that list as being something that bothers people who are caring for people with dementia? So a lot of our focus in trying to improve dementia care is focusing on things that we all know are not going to make any difference to the extent to which a carer is prepared to continue to look after the person with dementia. Now, sometimes I express this badly, and what happens is people say, oh, you're just putting all this pressure on families. Why should families have to deal with this? All these women, because the majority of carers are women, although there are very many men. All these women, it's a feminist issue. You're making all these women go on caring when they're beyond the point of being able to do it. The real issue is this. The people who do caring because they love the person, they want them. Your husband says, I'm not her carer, I'm her husband. Why would I want her not to be sleeping in the bed beside me? We've been together in this bed for so many years. The things that give the carers a real problem are the things which the researchers found out on this particular piece of research. And of course the problem was they found all this out, but they put it in a paper that was really, really big and complicated. It was, it sat on the table, it was about 6 inches tall in paper. So at the University of Stirling, we translated it into the simple little yellow book, which is 10 hints for carers on each of these things. And these are things that will actually help people who are caring for people with dementia to keep them at home. So apart from the fact that the family might want to keep someone at home, why would you want people to be kept at home? And the answer, I'm sorry to say, is financial. We are not going to be able to afford to provide institutional care for all the people who are going to have dementia in the future. We're just not going to be able to provide that support. And when they have these dementia symptoms that are described here, it can be caused by a range of diseases. Alzheimer's disease is the most common, vascular disease, there are other diseases. And there are things we can do to reduce the likelihood of vascular disease. And there are some medications that help a little bit in Alzheimer's disease. But in reality, we can do things to improve the symptoms without actually affecting the disease at all. And if you want the person to stay at home for as long as possible, then reducing the symptoms that bother the carers is a really important task. Is that making sense? Yeah, what we're saying here. So I'm just going to take some water. I use this diagram a lot when I'm describing the problem in dementia. And sometimes I even change what we say is the label on the diagram. So on the top line it says mild dependency, but you could say on that line care at home, the person who needs care at home. Or the line lower down you could say extreme dependency or needing to go into care. And those of you who heard me speaking earlier this week would know that I've said I'm planning to be 90. And when I reach that age, I have a 50% chance of having dementia. So when I have dementia, this is the journey that I want to have. I want to stay above the line of having any interfering busybody in my home for as long as possible. And if I do have to have care at home, bearing in mind that I'll probably have to pay for it, I want to pay for that as short a time as possible. And then if I get to the stage where I'm so frail, I want to be in that residential care for as short a time as possible. And that's largely because it's going to be so expensive and I want to leave some money to my child. I'd like to leave a little bit of inheritance. My colleagues in America don't understand this. They've got a really strong sense that what you do is you earn all your money to have a really good life and you give a good education to your kids and then it's up to them. But certainly from a UK point of view, we have this idea that it would be nice to hand something on. So if I have that journey there, because that's the less expensive journey, that's the journey I'd like to have. And just towards the end there, that's me falling off my motorbike on the way home from an all-night party. And I was only going that fast because Barry was headed out there before me. So you want to stay as well as possible until the very end. But unfortunately, a huge number of people go downhill faster than is necessary. And the journey downhill like that is sometimes seen as something that is inevitable. But the reason why I've got all these little arrows on the diagram is to show that there's a whole range of things which will actually keep you higher up. And among those things is your family having knowledge of how to deal with the common problems that everyone knows a person with dementia is going to exhibit. So if I have got dementia and I go to see my doctor or my nurse or my voluntary organisation, and they can't tell me all those things that I can do to keep myself on the top line. What they're effectively doing is shoving me down the way. They're pushing me down that hill. And if my family goes to the GP or the nurse or anybody else and says, what can we do to keep June as well as possible so we can save all her money for champagne and shoes after she's gone? If they're not told, then what they're doing is contributing to me being pushed downhill. And there is some research evidence, as we said earlier in the week, about what it is that would keep people up on the higher level. And we can talk about that later if there's time. But one of the really awful things that would happen is, and I know there are some people here who haven't heard the story yet about the wine, the research that shows a glass of red wine helps you resist the symptoms of dementia, a glass of red wine a day. That research came from the University of Bordeaux. And fortunately, there's some new research from the University of Reading that says champagne has the same effect, so I'm protected. But unfortunately, what happens is if I'm coming out the wine bar in Stirling and I fall and fracture my neck of femur, my chance of getting back to my previous level of functioning is very, very low. And the question we often have to ask ourselves is, was there something happening before June went into hospital that was only discovered once she was there? Because quite often the story people tell was, once we got her in, we realised our family wasn't coping. Actually, what the research evidence suggests is that once I'm in hospital, the hospital's like a meat grinder for people with dementia. It chews them up. And it's actually the hospital that turns me into a person who can't live independently at home. And I'm just going to show a little film, which some of you have seen earlier in the week, that illustrates what this problem is. So there we are. I'm doing pretty well. I'm taking my exercise, I'm socialising, I'm doing all the things that I'm told really make a difference. But then something happens. So if you just excuse me, I'm going to put up the little film.
My name is June Andrews. I'm 84. This is the story of my trip to hospital. It started one Friday evening when I had a fall in the bathroom. My husband called the out-of-hours doctor, who told us to call 999. Arthur couldn't help me get back up on my feet. I had a nasty bruise over my right hip. I wasn't keen on coming into hospital, but they persuaded me.
I was on call when Mrs. Andrews was brought in, and I arranged a hip X-ray. There was no fracture, but some blood and urine tests showed that she was a little dehydrated and had a possible water infection.
Mrs. Andrews was moved on to the acute medical unit. She was getting close to breaching the 4-hour target. It was also getting late, and the AMU was a safer place to assess her and get her back on her feet. We put up a drip and gave her some antibiotic tablets for the urine infection. On Saturday morning, she was seen by the on-call medical consultant. Before we could look at her mobility, the patient flow team insisted we move her to the first available medical bed. She was not reviewed again medically till Monday. There is no routine physiotherapy or occupational therapy over weekends, so we couldn't refer her to the home rehabilitation team before then. By Monday, June had been on either a trolley or in a bed with the cot sides up for 3 nights because she was deemed to be at high risk of falls, and the nurses had inserted a urinary catheter. She was seen that Monday morning by the physiotherapist, who got her out of bed with the aid of a Zimmer frame. My home ward is in the elderly care unit. We do our best to provide a regular liaison service to other wards, although we wish the doctors there had more knowledge about managing older patients. The ward doctors and occupational therapists made a plan to get some more information about June's usual abilities and past medical history.
I'm June's husband. On Monday, I was able to get back into the hospital to see her on the ward. I told the ward doctors and nurses that June had been getting more unsteady recently, had suffered another fall, and that her memory isn't what it used to be.
The review team discovered that her blood pressure was dropping very low when she stood up, postural hypertension. It often leads to falls and faints in older people. We stopped a couple of her cardiac medications to try and solve this problem. By Wednesday, she was able to stand with assistance. The physios came to see her, and a plan was made to refer her for ongoing rehabilitation. in the local community hospital before going home. But not for the first time. There were no community beds, and by the 10th day of June's admission, the cardiology ward desperately needed beds for acute cardiac patients, and she was moved to a winter escalation ward. After all those moves, Mrs. Andrews had become confused and agitated. She had another fall, sprained her wrist, and now she required 2 nurses to transfer her from bed. June spent increasing time in bed with the cot sides up. By day 12 of her admission, the community hospital phoned back saying that she had no rehab potential and should have a care package instead. She was referred to social services with a target discharge date for Friday, but the package couldn't be put in place till the following Tuesday. She went home with a 3 times a day care package, but with no clear diagnosis for her progressive memory impairment and falls. 7 weeks after her discharge from hospital, June had fallen twice more. Her memory was worsening and Arthur was becoming stressed, concerned and exhausted. June ended up being admitted for respite to a local care home. Mrs. Andrews never got back to her own home after her respite. We should have more care and support for older people like her outside hospital, and those services need to respond much earlier to people's needs. But the way we treated her in hospital and our difficulty getting her back on her feet and home again didn't help. With so many frail older people coming into hospital, we have to get this stuff right for everyone.
So there we have the story, and do you know, they accidentally called her June Andrews. I couldn't believe that, because once they'd put the thing on the website of the British Geriatric Society, the guys rang me up in real embarrassment because somebody watching the film said, did June Andrews agree to her name being used? And the guy who wrote the script said, well, who's June Andrews? And obviously it was just a name that he'd heard and it had stuck in his brain. So I just hope it's not prescient. I hope it's just not saying what is actually going to happen to me. And I'm looking forward to meeting Arthur. He looks okay. So, given that the talk today was to be about how you make change happen, there's a huge amount that one can say about this, and all I can really do in this session is to talk about what our change theory is, what we believe makes change happen, give some examples of how we go about that. And the first and most important thing is you have to know your stuff. I'm astonished as I travel the world when I meet Alzheimer organisations where the name is Alzheimer organisation and the people working there are called the Alzheimer navigator or the Alzheimer person, and those people actually don't know an awful lot about dementia. There was a time when nobody knew much about dementia and anything was better than nothing. But now if you've actually got specialist people who are meant to be specialists in care of older people or care of dementia, it's really important that the level of knowledge they have is quite high. I met the fantastic people who just graduated from the Walking in Other Shoes programme. I might be saying the name wrong. Met these fantastic people yesterday. These are people who are relatively unqualified, relatively simple workers in terms of the difference between them and a GP. But these people had a profound understanding of dementia, which meant that they would be very good at their job. But there are very many people who are working in senior positions who don't have that level of knowledge about dementia. The second thing is we see quite often internationally that people don't know the system, how to make things change. They have things that they're concerned about and they worry about it and they think there's nothing can be done. It's really important to know who is in charge and how to influence that person in the system. We talked about this earlier this week in the seminar. And the thing also is to be really professional. In terms of making change happen, you've got to be able to make the case, you've got to know what is going to make a difference, and you've got to use really high impact communication. That's what this video does really well, because it illustrates something. The number of people who will come up to me and say, you knew my mum or you knew my auntie because this case of the person going into hospital, whether it's for a fall or a urinary tract infection, is something that's really, really common. The other thing you've got to do is collaborate with other people. You've got to make sure that other people agree and will work with you. And you've got to use your time the best way you can, because so many of us waste our time doing things that are not going to make any difference. And one of the really good ways of using your time is to, when you've got something where it's only a once in a lifetime decision, such as the design of your hospital or your care home, it's really, really important that you use the design in a way that's going to save time for staff. So, for example, it is quite clear that people with dementia will walk more safely over a smooth, matte, self-coloured surface. And if you're designing a hospital or care home and you start putting shiny vinyl on the floor, or you start putting patterned carpets, you start having fancy strips demarcating the threshold between rooms, you're going to increase the number of times that people with dementia fall over. You can take an example of a person with dementia who has depth perception problems, people with dementia who, for reasons to do with visual perception, misperceive shadows and changes of colour as changes of height. When these people stumble, we all stumble sometimes, but when these people stumble, they will fall, they'll get that fractured neck of femur, and they will end up in the hospital. And why is it that people with dementia with fractured neck of femur are the people who are making your length of stay in hospital longer than everyone else? The reason is a lot to do with the fact that the way the orthopaedic department is working completely discounts the fact that the majority of the people with that problem are probably very old and probably have some of the problems that dementia brings. And so things happen to them, like happened to Mrs. Andrews in hospital. Things happen which mean that they will get delirium and they will stay in hospital for longer. Delirium is something which comes on because of the stress in your brain caused by cortisol. It's made worse by dehydration. Putting someone with a catheter in is almost guaranteed to give them the kind of infection or the kind of syndrome that will cause delirium. Putting cot sides up so that person with these problems who's perhaps starting to wander, putting cot sides up so they won't move is a form of restraint which in itself will lead to delirium. And if you've got a heart of stone and all you want to do is get them out of hospital fast, then you've got a whole cadre of staff who are actively working towards that person not going home as fast as anybody else. If you add to that the relationship between pain and delirium, the fact that people do not use proper tools to assess pain in people with dementia means that the people with dementia don't get pain relief, and as a direct result, they're pushed further towards delirium. So you have a whole highly expensive healthcare system that's shoving somebody towards staying longer in hospital and becoming so unwell in hospital that they never get back to their previous level of functioning. Now, if we just wind that back to the care home where somebody decided that there would be a fancy carpet and the person tripped because of the fancy carpet, how much money would be saved by just choosing the right carpet or the right floor covering and choosing it once? You only have to make that decision once. I expect a fancy one costs more than a plain one. But if the research shows that, given that the commonest reason to be hurrying in a place like that is maybe trying to get to the toilet, if the research shows that that floor covering will make the person with dementia walk more smoothly and swiftly, then think of all the laundry you're saving, think of all the smells you're preventing. I have visited a care home recently where the smell of faeces in the corridor was quite strong. The interesting thing about the air quality was nobody said, oops, sorry, somebody's done a packet. Actually, what happened was everybody just behaved as if this was the way a place like this would smell. Everybody knows that somewhere smells bad sometimes. Goodness knows I've done enough long distance flights to know that. But the key thing is you've got to recognise that simple design changes can actually save a huge amount of money and time and effort and humiliation. So using your time just to, for example, put in the contract that nobody gets the business of redesigning this building, this hospital or this care home, unless they can actually prove that they've had dementia design education. You can get that from the Dementia Centre, but other providers closer to New Zealand are available. But the other thing in our change theory is you have to be lucky. It was one of the things that was said last night. You know, the more you practice, the more lucky you get. So you are really lucky at this time in New Zealand because although you have an ageing population, your health system is probably not in the difficult financial state that some of the Western European health systems are. You're really lucky in that you've got a highly educated workforce and you're not suffering yet from the shortage of qualified nurses that exists virtually everywhere else in the world. So you're very lucky, and the thing to do is build on your luck now before your luck starts to change. There are lots of simple things that you can do now, and if you do them very quickly. So looking back at the change theory, one of the things we know is that educating families makes a significant difference. If you're not focusing on that now, you're missing out on a really important opportunity. So we've got some of the hints there. And that's one of the reasons why we produced these little booklets for people in the UK. You would have to read them and tell me whether or not they work for New Zealand. But these booklets are on things. On the pink one is on design changes that people can make in their own house. If you want people to stay at home, you have to advise people to increase the light level and change as little else as possible apart from moving trip hazards. The green one is about something that I was asked about before coming here, which is about dementia-friendly communities. To be honest, there's not a huge amount of evidence that the things that are called a dementia-friendly community around the world make a significant difference. Some of them are doing things which make differences, but the fact that something's labelled a dementia-friendly community doesn't in itself make it something that's working. The one in the middle I think you probably don't need here because it's about heating for people with dementia. In Scotland there's a lot of fuel poverty or perceived fuel poverty among people with dementia, or people who still think that £100 fuel bill is a big one. And so they'll be cutting down on their fuel. It's really important to keep the temperature right. And then the other two you're familiar with, which is the 10 hints for carers and the Blue Book. So I have hundreds of stories that I can tell, and I've been telling over the last few days about the sorts of things that you can do. We had some of these the other day, but just checking is one that I don't think I've spoken about in a plenary session. Very many people get moved into their care home because families are worried about how they're getting on at home. And there is a website called AT Dementia where you can see a range of assistive technology that is easily available and commercial and low cost, which will help alleviate the anxieties that families have about somebody staying at home by themselves. And just checking is one I particularly like, where you get a little sensor, one for the living room, one for the kitchen, one for the bathroom, and one for the bedroom, and sensors for the front and back door. And on my smartphone, I can see a tracing that tells me if somebody is moving in the house, so that I can see my dad's moving in the kitchen, then the bathroom, then the kitchen, then the living room, and then the front door opens and shuts and he's out. And I can set an alert on my phone because I know he's usually out for 3 or 4 hours. That takes him to the church and the supermarket. But if he's out for 5 hours, that's too long and something's gone wrong. And I can have an alert on my smartphone that tells me he's been out too long. And when I look at it, I can actually see where he is on the map. So these are things that you can easily have. These are things that are commercially available now. So there's absolutely no reason for me to lock him up every time I come to New Zealand and put him in a care home. Because if I needed to, as it happens, for veracity, my dad doesn't have dementia and he doesn't need that yet, but I know that people in my position would be able to do that so that they didn't have to put somebody away just in case. And putting people just in case away is a thing that we can't afford. Even care homes who are worried about losing people may not be aware of the assistive technology that you can use to track people, so that they as soon as they get near the boundary, somebody is alerted to go and fetch them back if there is a real danger. Delirium I think I've spoken about. And the last thing I'd like to speak about is the question of user involvement. I think that people exaggerate how brilliant Scotland is. You know, the thing in Scotland is you're really modest about stuff. There's really showing off is really bad karma. And that's why it's clear that all our civil servants must be English, because what happens is whenever you go to an international dementia conference, there's someone from the government saying that Scotland has cracked it, and although we're doing really well on some things, we haven't. But the one area where we are doing, I think, certainly leading in the world, is in the involvement of people with dementia. In Scotland, you would get hammered for having a conference like this and not having people with dementia in the audience. It would just, you see these empty front rows here. These are the seats for the people with dementia. And the room out there would be the room with refreshments, so they could get up and go whenever they felt like it. And the spare seats would be for the people who came with them to look after them if things got tough. And the programme would absolutely, it wouldn't be, 45 minutes of Professor Andrews. It would be 30 minutes of Professor Andrews, followed by however long he wanted of the man with dementia, who would speak about his experience. Now, it's a really difficult thing to do because a person with dementia only has the experience of one person with dementia, and what they are demanding can be as wild as euthanasia or, you know, free housing or whatever. You don't know what is going to be said, but it's a risk you have to take, because otherwise what you're doing is trying to manage people back into a box that you yourself have designed without any real knowledge of what it is they're living with. So user involvement is something that we're very, very good at, I think, in Scotland. And our users have gone feral, I can tell you. They're absolutely, you walk up to see a government minister and they say, yeah, the Scottish Dementia Working Group has been telling me. I'm waiting for the day when they say they don't need universities anymore because, you know, we'll be dead, that'll be it, it'll be done. So in making your changes, as I said before, use the resources that exist. We've got loads of resources that are available. For the design issues that I mentioned, we've got the virtual website, the virtual hospital and care home on the website. It's really, really important that you get help where you can understand your system and be effective. And I'm sorry I'm going through these really, really fast because, as usual, as ever, I ran out of time because I love to talk about these things. Just want to finish on the idea of the Dementia Festival of Ideas. We ourselves, even at the Dementia Centre, after 25 years of great success, had got to the point where we thought we knew and we were giving out a message. And what we want to do is draw people back to a place of uncertainty, where we're saying that we are still learning. We've got things to learn from other countries. And journalists always say to me, oh, what would be the best country to have dementia in? And the answer is, for some things, it would be New Zealand. For some things, it would be Scotland. You know, as I've said, for user involvement, it might be Scotland. For some things like nutrition, it would be France. I have good stories about that. From some other things like family involvement, it might actually be the developing countries where the number of people with dementia is increasing faster than it is in the developed world. So it's important that what we do is keep talking to each other internationally, and the communications technology that we have allows this. I have absolutely loved coming here to New Zealand because the bubbles are great. That, you know, the sparkling wine is great, and the nosh is great, and the people are great. It's great being here, but we don't actually have time to cross the world to talk to each other, or for all of us to cross the world. So let's use the other technology and keep talking. So you know where to find me through the website. I promise to answer any question from anybody who's been a delegate here. And if there are things that you think we are missing, then let us know, because now that I've completely impoverished my charity, they'll be in a good position to ask for more money from other people to do more things. So thank you very much. Thank you.
How about that? I just got a gold watch. Didn't get one last week. No hard feelings at all, June. I see Barry has returned. He didn't mind getting back in here. Thank you very much. Right, let's just get on here. Now, that video, Mrs. Andrews' video, of no relation at all, did that send a message? Did that just sound like our health system? Didn't it? By golly, it's pretty powerful when you see it all in one continuous story. June asked us to do several things here, but the first one thing that we must do is the Big Ask website, and give you views on that. So the Big Ask, was it the Big Ask? It was the Big Ask, okay. That's the first thing. What a wonderful approach to engaging with the public and the community and the media. Not so much about expressing knowledge, but asking for input. Yes, there will be some imparting of knowledge both ways. What a fantastic style that you've just talked about, June. And made the message very, very clearly that knowledge is powerful, and some examples given there, and some powerful examples. Resources are available, toolkits are available. It's about finding and using, and I think that's that for me that would be one of the key messages that also came out of here. But the one thing that you imparted upon us so well was your style. The delivery of your message, it's strong and it's powerful in its own right, but your style you put the statement so simply, and you take away some of those the mystery and the myths of dementia. so that it would be much easier for us now to engage freely amongst ourselves and with others in some area where perhaps we might have felt a wee bit restrained or restricted. So thank you for that, June. And very, very interesting about the user involvement. It might be something we have to contemplate. You know, we're thinking about it in other settings. I don't know whether we've thought about it in our conference settings. Something that we will obviously need to think about in the future. So it's great delight, I say thank you very much again to June Andrews, Professor June Andrews. We've really appreciated your presentation today, and it'll stay with us, I think, for a long, long time. Thank you very much.